Good morning, everyone. Welcome to Rounds. I will go ahead and get started. Maybe. There we go. Now I'll get started. Okay. This is not that one. This is a 15-year-old domestic short-haired cat with a history of glaucoma diagnosed in October 2023, suspected topical reaction to dorzolamide, so they transitioned to brinzolamide, and then returned to us at the end of January with a ophthalmic eye that was unable to close the lids over the eye. The intraocular structures were not visible due to corneal edema and neovascularization. The cat, let's see here, also has, I'll withhold the rest of the history because it would just give it all away. So here's the globe. Cornea is always at the top in our gross photos. As you can see, the globe is filled with this weird flocculent tan material. And when we look at the iris here, it's quite thickened and off-white, and the iris on the other side is the same. And that sort of thickening does kind of extend down into the ciliary body a little bit. And here we can see the lens capsule, but we actually can't see anything else. So there's probably a hypermature cataract here. And everything else is pretty much obscured with this shmoo, which is a great pathology word. So let us take a look. All right. Oh, that's why. You did have it right. I just didn't have the.
I see.
Okay. Oops. What did I just do? Okay. Sorry. Technical difficulties, but not really. All right. I'll try to keep the center in focus and speak about only the center. Okay, so here's our cornea. It's quite busy, so there's quite a bit going on there. And then as we move back into the globe, you can see that tan flocculent stuff that we saw in the gross photo corresponds to this pink kind of dense stuff. When we look at the iris here, it is expanded as we saw grossly, and it is also quite busy. So there's quite a bit going on in the iris stroma that does extend back into the ciliary body a little bit on both sides. It looks like there's something similar happening in the episclera here. And then when we move back to the retina and the optic nerve, similar weirdness is happening in the optic nerve and the retina. And then here's our extra gonio slice with similar stuff happening. So there's a pretty extensive disease process in this eye. All right, sorry. Okay. So we can get started with the cornea. The corneal epithelium is thickened, so it is hyperplastic, and the stroma is quite busy. So we have corneal epithelial hyperplasia and corneal stromal fibrosis and vascularization. Look at this gigantic blood vessel there. And then as we move further in, we start to pick up something abnormal. So this is not corneal endothelium. It is much too thick for that. Let's take a look at what it is. These are some polygonal to cuboidal cells lining the back of the cornea. They're kind of forming a jumbled layer. And that is similar to what's happening in the rest of the globe. So when we look at the iris stroma, we have similar looking cells that are forming cystic structures and lining them in the iris stroma. One might argue that some of these are lining the lumens of blood vessels. Sometimes it's a little hard to really hang your hat on that confidently. But they are forming these sort of epithelial structures, if we can at least say that. And let's go higher. So the cells themselves are cuboidal to polygonal with indistinct cell borders. They've got quite a variation in nuclear size. You can see one relatively large nucleus here next to a smaller one. And they do have prominent single nuclei. And as we go back, you can see those same cells are lining the exposed choroid there. They are infiltrating and effacing the optic nerve and extend right to the optic nerve margin. And they are also infiltrating and effacing the retina. And the retina, other than being infiltrated where you can still kind of tell that it's retina, which is even debatable here, is otherwise necrotic. So probably this is due to ischemic necrosis. When we look at all that stuff that was in the ocular chambers, oh man, it's so dark. It's basically a mix of eosinophilic proteinaceous material, some red blood cells, and then a lot of other cells that are macrophages with stuff in their tummies, and also probably some neutrophils, and possibly also some sloughed neoplastic cells, but it's like basically impossible to really say that with confidence. Let's see here. I just wanted to. I was going to give you another gander at higher power of these neoplastic cells. Anyway, so what we're seeing here is an extensive epithelial neoplasm that is basically infiltrating and effacing the entire uvea, the retina, and the optic nerve of this eye. It also does extend out through the limbal sclera, and it's occupying the episclera on this side of the eye. So this is consistent, and it's also, I said it, but I didn't really stress it, but it is carpeting surfaces in this eye. So this is the pattern that we see particularly with metastatic epithelial neoplasms. So this is a carcinoma of some sort. You could argue that it's forming glandular structures, so we could call it an adenocarcinoma. And in cats, the most common metastatic epithelial neoplasm that we see originates in the lungs or the respiratory tract. And in fact, this cat had a history of a pulmonary mass with pulmonary metastatic nodules. So presumably this is what this is. However, the cat also has a right adrenal gland mass with intravascular infiltration of the caudal vena cava, left adrenomegaly, and also hyperthyroidism and a partial bundle block. So this cat has all kinds of problems. I don't believe this is consistent with an adrenal mass. I really strongly believe that this is probably associated with the pulmonary mass. And this is a really interesting case because they said pulmonary mass with pulmonary metastatic nodules that is presumably intra-lung metastasis of the original mass. I think that a lot of the stuff that we're seeing in the ocular chambers is probably secretory material from the neoplastic cells. That is sort of a big guess, but we see this occasionally with the metastatic pulmonary carcinomas, where we think that there's secretory material inside the ocular chambers.
And I also agree. I think you're right when you said that a lot of those cells are slipped, degenerated neoplastic cells floating around.
Yeah. Yeah, I mean, it's really hard to tell, but yeah. Yeah. Anyway, so kind of sad news for this cat, but hopefully he's had a good life. So as I said, pulmonary mass with pulmonary metastatic nodules per history, and then extensive intraocular metastatic carcinoma with vascular invasion and dirty posterior scleral and optic nerve margins. Oh, and limbal scleral, I think. Okay, moving on to the next case. This is a 6-year-old border collie with a history of buphthalmia, corneal edema, history of very dilated pupil for years, apparently, and a cupped optic nerve head. They say the iridocorneal angle is narrow in the contralateral eye, so they have diagnosed corneal dysgenesis. So their rule outs were primary glaucoma, but why such a dilated pupil? And they ask, is it a coloboma? So this was kind of an interesting one. When I held the globe in my hands when I was grossing it, and so I could not see the iris. But when I pushed gently on the limbus to try to pop the iris into view, because sometimes that works with a very dilated pupil, I still couldn't see the iris, but what I could see were the little finger-like ciliary body plicae sort of extending, in their normal anatomic location. But when the iris was just not visible, you could really see them, and it was really kind of cool to see that. But other than that, when I hemisected the globe, the choroid is very hypopigmented. So this is consistent with a blue eye. And then when we stared at this for a really long time, we decided that there in fact was an iris. So here it is right here on one side of the eye. The other side of the eye, it's a little bit harder to make out, but you can also see it sort of deeper in this hemisected globe. So it is poorly pigmented. So this is once again consistent with a blue eye. And at least on this side of the eye, you can see that there's pretty prominent ectropia and uvea, where the pigmented iris epithelium is being brought around to sort of curved around that pupillary margin. And maybe it's hard to tell what's happening on the front of the iris right here. But anyway, so we found the iris. It's not what you think.
Before you move, show the ciliary processes you were seeing through.
Here.
See them next to the.
You want to show? I don't know, like right here.
Yeah, kind of next to the lens. Yeah, right there. They created.
Yeah. So it was really cool. They look like little black fingers. It was kind of cool. I've never experienced that before. Anyway, all right. So let's go check out our slide. All right. Okay, center is in focus. Okay, we have some little bit of artifactual curling of the cornea, so it's not completely sampled, but that's okay. We don't need it. When we move here, you can see ciliary body. So here's some plica. Those are the plica that I was seeing. And then there's some sort of uveal tissue here. There's some sort of something plastered to the back of the cornea, and there's the pigmented iris epithelium present on that side. Over on this side, we can actually see that iris leaflet. It's what we call miniaturized or nubbinified. The iridocorneal angle is abnormal, so there's no ciliary cleft present or identifiable, and the trabecular meshwork is collapsed. And then when we look at the gonio slice, we also have, so here's a more recognizable iris. It is abnormal, however, because basically iris is separated from the sclera, because the ciliary body and its plicae are actually look like they are lining the back of the iris. So that's abnormal. So this is an area where the iridocorneal angle is recessed. So iridocorneal angle recession. In addition to that, we can see that the iris epithelium really does kind of extend around in front, into the front of the iris here. And overall, the iris is kind of an abnormal contour. So, where are we? All right. So here we are back up at the front of that whole section of the eye. And actually, I don't want to start here. Let's go to the other side. Okay, so believe it or not, this is the iris leaflet. And when we get a little bit closer, we can start to detect that it is perhaps a little bit more hypercellular than we would expect. And it's not hypercellularity due to melanocytes, for example. It is, in fact, hypercellular because there's quite a collection of atypical spindle cells in here. Oh man, it's so dark.
Go look an exit and
Hold on just a sec.
Escape.
Audience.
Automatic there. And now click it out.
Okay. All right. So technical adjustments here. So we have a population of atypical spindle cells. They have indistinct cell borders. They're sort of haphazardly arranged. There's quite a variation in nuclear size. So you can see this gigantic nucleus down here. Now he's up there. Here's one with a big old nucleolus. Mitotic figures are pretty rare. But so we've got a neoplastic population here. And actually, I'm going to zip back to the gonio slice because we have a little bit more cells to look at in this one. And we can also more easily appreciate that, sorry, ectropion UVA, where the iris epithelium is being pulled around front. So here are more of those cells. So as I pointed out on the gross photo, this is a blue eye, and we have sort of a nondescript-ish spindle cell neoplasm within the iris stroma. So this is consistent with an iris, a uveal schwannoma of the blue-eyed dog. So they are notorious for causing weird distortion of the iris, including ectropion UVA, where they, for some reason, they very commonly will end up pulling that iris epithelium around to the front of the iris. In fact, some cases come to us with a history of iris color change from blue to brown. And that's the reason why, because that iris epithelium is being pulled around to the front of the eye, to the iris, excuse me. So, and in this case, it also greatly distorts the iridocorneal angle. So that gives us a really nice reason for the glaucoma that they diagnosed. On this side in particular, I said that there was iridocorneal angle recession. Let's see here. So this is an end of Descemet's membrane. I'm not sure if it's a broken end or the actual anatomic terminus. But when we go a slightly lower mag, if you keep your eye on that spot, and then we travel down to where the base of the iris is, it's greatly posteriorly displaced. So this is iridocorneal angle recession. This could be due to either trauma, like cyclodialysis. Blunt trauma is usually what causes that, or it could be due to just neoplastic distortion of the architectural features of the structures in that area. I'm not sure which it is in this case. So we always consider trauma to a blind eye to be a reasonable thing to suggest. I don't think clinicians and owners necessarily like to hear that, but I think it's something that Coplow says all the time. But anyway, because when an eye is blind, the animal can't protect it from damage, from being injured. At least with flying projectiles, for example, or walls that are coming up quickly when running. Anyway, so let's see here. What else do I have to share? We can go look at the retina and the optic nerve. So the retina is quite atrophied. So right there, we're basically full thickness atrophy. And then when we look at the optic nerve head, it is atrophied and recessed. So it's cupped. So those are the most important parts of this case. I'm trying to think of what else I should say about schwannomas. On a very rare occasion, we have diagnosed them in brown eyes, excuse me. But that's pretty rare. They can be fairly difficult if you really are trying to, so generally speaking, some of the cells in these tumors will express GFAP, which is kind of weird. However, the expression is not consistent across most of the neoplasms, and it's often very faint. It can be slightly difficult to differentiate these between this and an amelanotic melanoma, because of the dirtiness of some of the immunohistochemical markers that we have. But usually, if it's got this sort of morphology and arrangement in a blue eye, we're pretty comfortable calling it a schwannoma. And that's all I have. So, somebody else's turn.
All right. Next up is a 4-year-old male neutered domestic short-haired cat that has a history of, this is the left eye. They report moderate blue thalamus, negative menace and dazzle, but positive palpebral reflexes. There was a superficial corneal stromal ulcer with corneal edema, some aqueous cell and flare 2 to 3 plus. They describe a large fibrinohemorrhagic clot that nearly fills the entire anterior chamber. And they were able to see some fibrovascular membranes and synechia on the lens capsule. They also described complete vitreal hemorrhage. And this has been going on for about 2 months. The other eye, unfortunately, is also not normal. They describe a moderate vitritis and exudative retinal detachment with multifocal areas of vitreal hemorrhage. In other general medical conditions for this cat, he's got a history of generalized myoclonic seizures for greater than 2 years that they presume to be epilepsy, but they've noticed a recent increase in the frequency of the cat. Other than all of this, the cat is apparently healthy and thriving and has normal blood work in the recent workup for these ocular changes, and was also negative for the toxoplasma serum test. So grossly, here we got the eye of our cat. Our cornea is up at the top. Anterior chamber has got this gel and hemorrhage in it. We can see iris leaflet over here. Then this one over here starts to look a little like thickened and irregular. We also noted that there was a little scleral bulge dorsal medially in this globe. So we cut it a little bit obliquely to kind of get this little bulgy area here. It's a little bit thickened. Our lens is in place, looks pretty good. And then we have all of this like exudative looking material in the back of the globe here. And likely that this is probably some detached retina in here as well. And we can't really see the optic nerve head. So let's take a look. Here we go. All right. All right. So here's our subgross view, cornea at the top. Here's that gel and hemorrhage in the anterior chamber, nice eosinophilic proteinaceous material. Here's the iris leaflets, see really thick and very hypercellular. The one on this side looks a little bit more pink. And here's that bulge that we noted grossly. Lens not too bad. And then you can see all of that hypercellularity extends circumferentially around the back of the globe, kind of into the optic nerve head. And then here we can see it again on our gonio slice. Okay. All right. So as we make our way around back to the front of the eye, we can see all of the hypercellularity that is just effacing the ciliary body and the iris. It's lining all the structures. You can see it extending towards the other side of the globe. Here's all that proteinaceous material in the anterior chamber and some hemorrhage. Here's the other side where the iris leaflet was looking a little bit more pink. So we have some areas that are hypercellular, and then these pink areas, which are necrotic. And the same for the ciliary body. It's much more pink here, very fibrillar material for necrosis. And then we can see that hypercellularity extending out into the limbal sclera and causing that bulge there. And then we have more fibrin and such in the vitreous, and then we can see all that cellular infiltrate lining what is choroid, because the retina wasn't very recognizable in here. So it is detached and kind of gone and effaced by what's here. And so if we go take a closer look, I liked this back area here. So we can see this cellular infiltrate of round cells. And if we take a look in the choroid, we can see a lot of round cells in here too, a little bit smaller than these bigger ones out here. So these are more of our lymphocytes and plasma cells, pretty typical of a lymphoplasmacytic, in this case, pan-uveitis. These cells were, you could still identify some of them in the iris and ciliary body, but back here in the choroid, they looked really good. And then you can see the difference between these larger round cells that are our neoplastic population. We've got kind of small amounts of eosinophilic cytoplasm. These nuclei are really big and round oval. They're about like at least two times the size of red blood cell width. We've got a prominent nucleus. Mitotic figures were pretty common to find in this tumor. And so the circumferential nature and it's very destructive. This is pretty typical of lymphoma here. Let's see. We can see that it does infiltrate into the optic nerve here. And we've got some cells that are kind of infiltrating into the meninges as well. It was a little difficult to definitively say that there's no neoplastic cells in here. They are a little bit on the smaller side, so maybe this is just an inflammatory component, but it makes sort of margin assessment a little bit difficult and hesitant on whether this is truly a clean margin or not for this lymphoma. Let's see. If we go back to the lens does have some cataractus change to it, but the lens capsule was intact. There was no evidence of inflammatory infiltrate in here, so no evidence of a rupture of the lens capsule, but still some cataractus change. And let's see. I think. And then actually we can confirm their ulcer of the cornea here. We've got the epithelium lifting off a little bit here at the edge. It's a little bit rounded and maybe a little bit disorganized. So an indolent ulcer also in this cat, which is not unsurprising to find here. So neoplastic inflammation, that's a good one. Inflammation, as well as this very destructive circumferential neoplastic cells consistent with lymphoma. So this is what is called, click the right button. So usually this has been called feline post-traumatic lymphoma or post-traumatic sarcoma round cell variant have been proposed or are classic terms for this. But I guess we've been seeing that it's not always trauma related. There's not lens capsule rupture, and the neoplastic cells seem to be coming obviously from the round cells from the lymphocytes in so having neoplastic transformation more of the chronic underlying uveitis that is usually present in these cases. And so I think we're in the process of trying to write up a case series and changing this name to like a chronic uveitis associated lymphoma.
And the papers should be at some point.
It's very close to being submitted.
Yeah. Just putting pressure on the reviewers now just by putting the name out there.
Yeah.
If you're a reviewer and you're out there, if you end up with this paper, there's no way out of it now. Just joking.
Yeah. And then for this case, this is usually like a primary ocular lymphoma. However, with this case, with having like bilateral changes in the eye, what they call the vitritis, exudative vitritis and retinal detachment, possibly with the increase in the seizure activity. In this case, there's concern that maybe it's a little bit more systemic than we usually see. So
yeah, these are hard because
yeah,
regardless of the origin, right? Especially, I think of it as similarly to like intestinal lymphomas in cats, where you have IBD, you have chronic inflammation that can become neoplastic. But even though we believe that because of the distribution of these cells and the way it affects the eye, kind of like a post-traumatic sarcoma, that these are likely primary to the eye, they're still lymphomas, and there's nothing that prevent us from becoming systemic after developing in the eye. right? So even though, we look for margins, we think it's a primary tumor. If you got clean margins with nothing else, with no signs of disease elsewhere, enucleation could be curative in a way, if you think as like a localized lymphoma. But at the same time, nothing prevents these neoplastic lymphocytes to do what lymphocytes do and just travel around and become systemic.
Mhm.
What differentiates it from metastatic?
So the question was, what differentiates it from metastatic lymphoma? And that's a great question. The distribution is the main morphologic feature for us. It forms this, circumferential mass-like lesion that grossly really resembles what we see with post-traumatic lymphomas, right? Sarcomas. Thanks, the more run-of-the-mill lymphoma that we have, they tend to be uveal infiltrative. It doesn't necessarily form just a localized mass, but it's more uveal infiltrative, tends to be more on the interior uvea and then spread around rather than having this super destructive circumferential effacement of the eye. That makes sense? All right.
Cool. Aha.
Cool.
Cool. All right. I
See
see.
that? Yeah. Yeah.
Need some special effects for rounds.
Yeah, you're right. Okay. Next up is another cat. This one, a 7-year-old male neuter domestic short hair. This is the right globe that comes with a history of chronic uveitis, hypermature cataract, preaortal fibrovascular membrane, and more recently, I think it was hyphema and iris hyperemia, I believe is what that says. There was no glaucoma reported in the eye, in that this has been going on for years. There is also chronic uveitis in the other eye. Grossly, what we have here, again, cornea up at the top. Here is one iris leaflet, and then you can see how this one, and you can see sort of into the back here, how thick this iris leaflet is and how white it is. The lens should be here, but it's don't really make much of like lens fibers. So looking for potentially leftover lens capsule here where it should be. Retina here is detached, forming this nice little tornado here as well. All right, and screen again. How I got in there. All right. Okay. So subgross here. Cornea up at the top. Again, hypercellular iris leaflets here. Lens should be here. He has, maybe we can make it this like darker pink squiggly lines here. That's the lens capsule. We can see that it's a little bit hypercellular behind it. And again, the retina is detached. We didn't sample the rest of the tornado per se, but we'll take a look at this tissue towards the back of the lens capsule here. And then here's just, again, more cellular infiltrate into the iris leaflets. All right. All right. So this iris leaflet, you can see is hypercellular. And maybe from low power, you get a sense that it looks a little bit inflammatory here on this side. And we'll just stay at this power and keep moving along. Here is lens capsule, kind of squiggles out here a little bit as we follow this along. We get here to the posterior lens capsule. You can see this nice little curling feature which is indicative of a true rupture of the lens capsule, where it kind of snaps and coils up. And again, we need sound effects here for our,
Where's my jaw hurt?
yeah,
Bring
boing.
it.
Here. I'll go back to that in just a second. Just want to show you the rest of the iris here. It's very hypercellular as well. So there really wasn't much lens fibers. I think there's some free ones back here,
The nucleus.
like the nucleus out here in the subretinal space, because believe it or not, this is retina that is detached here. We've got more kind of a cellular infiltrate on top of that. And so if we look here in the lens, we've got some like fibrous metaplasia of the lens epithelium. And we can see it kind of coming around the lens capsule, posterior migration, and kind of heading out into what these streams of spindle cells are starting to form here. And so we've got the streams of spindle cells kind of extending from the lens capsule rupture. They extend all the way down here. They line the ciliary body here. This is a little bit more inflammatory on this side, but again, we've got cells lining it, and then they cross over the pupillary margin here on top of the lens capsule. And then we've got these spindle cells expanding and effacing the iris and ciliary body. I think on the side it extends into the choroid, which I'll show you in a second. But spindle cells, there's a lot of pleomorphism here. You got kind of a little bit bigger nuclei, some mitotic figures. And so this is a spindle cell tumor, so a sarcoma. The lens capsule rupture makes it post-traumatic. There's some areas of necrosis throughout here. You can see kind of our loss of cellular detail. Here it does extend a little bit into the choroid, but kind of peters out as we hit towards the back of the globe, where we didn't sample the optic nerve or optic nerve head, but this is about where it probably should be entering, but it stops well before that. And then as this is, like I said, sort of an extension of a neoplastic transformation of the lens epithelium, sometimes they still produce basement membrane material amongst the neoplastic cells. So I have a PAS stain. Can't see, let's go back. All right, let's see if I can, maybe sometimes it's very subtle. So we can see this nice, strong magenta staining to the lens capsule here. Let's see if I can find that special spot. And kind of amongst the neoplastic cells, you can see kind of fragments and, sorry, it's a little bit wrinkled here, but you can see the bright magenta material being produced by these neoplastic cells. So consistent with malignant transformation of the lens epithelium, producing this sarcoma. And since I didn't really show you the retina on the H&E, here it is here. You can see that it's just pretty much gliotic. There's no retinal ganglion cells. PS highlights the lovely blood vessels in here. So retinal detachment as well. And then apparently on their ophthalmologic examination, they were able to see apparent pallor to the lens capsule with the lens capsule rupture. So they were actually able to see that clinically. So that was pretty cool that they were able to see that. So feline post-traumatic sarcoma, the spindle cell variant, again, arising from neoplastic transformation from the lens epithelium that's getting outside the globe there and kind of doing its thing. And then here at Coplow, we've actually got a project going on where if you see any of these cases of post-traumatic sarcoma, or think you have a case and are looking to enucleate, we would love to have fresh tissue from these cases. So if you could reach out and talk to us beforehand, we will ship you materials that would be needed to collect the globe, because we wanted some frozen tissue samples as well as fixed tissue samples. And we have a whole protocol and would love to talk to you about that.
And we will evaluate your case at no charge
Yes,
if you help us with this.
so be on the lookout for post-traumatic sarcomas in your kitty cats.
But get in touch ahead of time
Yes,
if you have it, because we
Yes.
need time to discuss the case and get the stuff shipped to you and then get ready so that you can send us fresh frozen on dry ice tissue after that, after the enucleation.
yes. All right.
Clouder of kitties today. I also have a pair of kitties. Cats. So here's the next case. Sure this is the right paperwork. Okay. So this is a 15-year-old spayed female Siamese cat. The history is, let's see, retinal detachment with superior temporal retina appearing attached with granuloma temporal to ONH within visual streak. There's multifocal fluffy white intraretinal pasties, and the fluid under retina is not clear. So presumably kind of a cloudy fluid subretinally. So this sort of fluffy multifocal appearance that looks like granulomas clinically, and we can see that grossly too. So Jamie took this really wonderful picture of the globe with the lens removed and tilted back so you can see more of the choroid in this hemisected globe. And you can see that the choroid is quite thickened, opaque, tan to white, and there are these multifocal raised regions. So a sort of lumpy, bumpy choroid. This is also a blue eye, and that's the main thing for the gross. So let's take a look at the histo. We can do a subgross first. So the anterior segment, we've got cornea up here and iris down here, is pretty quiet. But when you go back to the posterior segment, that's where all the interesting stuff is going on. You see this very basophilic looking area associated with choroid and retina. And you see your retinal detachment here with some subretinal debris. And you can even see these sort of multifocal raised areas in the choroid. And we can take a closer look at what those guys are. So now the cornea is on our right, so it's flipped, but here we are in the back. And we can see that there's a really thick epichoroidal membrane. So I'd say that the choroid itself ends maybe like here-ish, and then everything on top is basically fibrovascular to collagenous membrane. And then those little raised foci are indeed essentially pyogranulomas, or at least just clusters of macrophages and neutrophils. So here those are. And this inflammation is pretty severe, infiltrating and thickening the choroid and in the retina as well, just as they said clinically, with some fibrin and inflammatory debris in the subretinal space, and pretty much complete retinal detachment. Although maybe there are some areas that look a little bit more attached than others. The retina is also showing an outer retinal atrophy, as you might expect with a detached retina like this. So we've sprouted a dot on our slide. And if we look closer in this area of macrophages and neutrophils, we will probably not see anything interesting. But if you squint and kind of turn your head sideways, maybe some of these sort of foci in the macrophages are looking a little suspicious. We've got kind of like a clear halo and then like a blue dot in the middle. However, it is not very convincing on the H&E, and indeed, oftentimes the causative agent, maybe,
Yeah, like
Uh,
this that you
yeah.
just showed.
Yeah, the causative agent is often not very clear on H&E. So I wanted to show you this at least to illustrate that, but we won't spend too much time on the H&E, and instead we'll switch directly to a GMS. We have a silver stain on this case. And this slide has also sprouted a dot. Very handy.
Color coordinated dots.
Indeed. Let's see. This was my attempt to catch the really cool one that we saw like yesterday, 2 days ago. Ah, where are you, friend? Oh, you're here somewhere. Come on. Hold, please. We will find him. Aha! This is one of my favorites in this case, because we do have a pair here that are budding, which is very cute. And it is theoretically narrow base budding, although we were actually discussing with this case that it can be kind of subjective, the
That
budding.
looks narrow.
It's like a bowling pin. Sometimes when there's like two budding pairs, they look like Mickey Mouse ears to me. But anyway,
Right.
there's just one in this case.
They're just reluctant to separate, they
Yeah.
bud and like need to go on
Still
their own
kissing.
now, and they're like, no, stay here.
So yeah, and we can see additional
Mhm.
yeasts out here as well. We can go ahead and call them yeasts. And there are some,
Give it a name.
yeah, we could give it a name.
Good. Good
So,
time to-
oh, sorry, go ahead. So this is histoplasmosis, probably histoplasma capsulatum. Here we go. This is my other favorite cluster in this case, which also sprouted a dot. Oh, but it's not really showing up very well.
Mhm.
But all these little guys here, let's see if we can get it on the 60X. There we go. All stuffed into a macrophage. You can see their little positive cell walls. So this is histoplasmosis, presumably histoplasma capsulatum. And it's mostly distributed in the posterior segment, which is very common for our fungal entities that manifest in the eye as a consequence of systemic mycosis. So we would suspect in most of these cases that the fungus has arrived at the eye because it's circulating systemically. And so concern about this case would be that there is a systemic histoplasmosis going on in this cat.
Anything in the history?
They did suspect fungal disease based on that clinical presentation. They said that they had a differentials of histoplasmosis and cryptococcus, and the Miravista tests were pending.
What's an important question about the patient itself? Right?
Yes. Another important question about the patient itself is the geographic location.
Mhm.
And so this patient is from Tennessee, which I'm extremely geographically challenged, but I am told that this is part of the Ohio River Basin or whatnot, where histoplasmosis is. So
called, right?
yes.
Yeah, so Ohio and Mississippi River Basin. So you can imagine like this big stretch coming down like the Midwest and following the Ohio and Mississippi rivers, and then sprouting around a little bit to the southwest US, but more concentrated in that area. It's kind of fun. We got a bunch of our cases, our feline ocular histoplasmosis cases, and we mapped it out using Google Maps, and then I overimposed the human distribution of histoplasmosis, and not surprisingly, matches perfectly. So the human ocular histoplasmosis cases and feline ocular histoplasmosis cases, they are, same location, of course, makes sense.
Endemic regions.
Endemic regions.
Mhm. Oh, yeah, really cool case. So we'll go back to the PowerPoint. Oop. And there's a diagnosis. And we can do the next case. So our second kitty we have an 8-year-old neutered male domestic short-haired cat. They describe an anterior uveitis in the right eye, superficial corneal ulcer, mature cataract. There's also hemorrhage inside the eye and a sort of segmental posterior synechia, and kind of a ventral mass effect of sorts has been described. So that's interesting. In the gross view here, this ventral mass effect is mostly associated with an anteriorly positioned iris leaflet. You can kind of make out the iris leaflet by its pigment here. And then there's all of this inflammatory exudate just behind it. And the lens is unstable. It's basically luxated and sort of pushing forward as well. So that mass effect is basically the bulging of all this stuff forward. And then the rest of the eye is pretty well full of tan to white exudative debris as well. And you can see that the uveal tract itself is a little bit thickened and distorted. So a pretty heavily inflamed, unhappy looking eye. So this one's really cool. You don't see this every day. Ah, there we go. There we don't go. There we go. Wait, let's get rid of all the fluffies. All right. Okay. So here's our cornea on the right. Here's our really thickened and anteriorly positioned iris leaflet that we were seeing before, and that kind of had that mass effect clinically. And this one is a little bit more busy than the last one we looked at, but still in the anterior chamber, there's mostly just this high protein fluid, so this eosinophilic material in the anterior chamber. And most of the actual inflammation is kind of behind the iris and posterior chamber, and along the choroid and affecting the retina, really severely distorting the retina. That said, just an overall much more inflamed eye than the last cat that we looked at. See, yes, we have the cornea on our right side again, so we flipped it again. And let's just start by zooming in right here at that sort of anteriorly positioned iris, and we see that it is very, very distorted by coalescing pyogranulomas. We have these cores of neutrophils surrounded by multiple layers of epithelial macrophages. So there you go. In particular, right here, a very nice example of a pyogranuloma. And then lots of lymphocytes and plasma cells between those as well. So pyogranulomatous and lymphoplasmacytic uveitis again, rather more severe this time. There was actually a lens capsule rupture in this case, which is interesting. Let's see. So we have inflammatory cells lining fragments of remaining lens fibers. And I don't think I really made out the lens capsule itself very well in this case. But let's see if we can take a look at some of this phaco spaghetti going on here. And not bad over there, but even better up here. So phago spaghetti is not a scientific term, but it's a fun one. And you can see all these inflammatory cells kind of lining the ends of the lens fibers and sort of phagostizing them. So the spaghetti noodles are the lens fiber in this case. So we have a lens capsule rupture, which is interesting in context of what's going on. Maybe we had an ocular trauma on top of the inflammation that was already going on. But now we're wondering what is causing all of this inflammation. And actually already as we go posterior in particular, we can see from low magnification even these giant blue dots amongst the inflammation. And if we look closer at those, yeah. And if we
JBDs, that's a new one. LBDs.
giant
blue dots, no, the giant blue dots. Beautiful.
we can see that they are fungal friends again, but a different fungal friend this time. So they have a wall and sort of flocculent basophilic contents. Let's see, it's called like a biconcave wall fruit. For some reason, the term is escaping me. It's not biconcave, it's something else. But these are fungal spherules is the appropriate term for these guys. Anyone else remember the term? What am I thinking of? Let me find you some of the other stages. So a lot of these are in the same sort of stage as the ones we've already seen, but there are definitely some others around.
Do you think about endosporulation or?
Yes, yeah, there are some really good examples of. Let me just find them.
There's a lot of them.
There are a lot, yeah. So usually in this fungal infection, we don't actually see this many organisms. It's actually quite,
Impressive
yeah,
and active inflammatory.
yeah.
Yeah, with them, you know, do you wanna
Aha.
say?
Yeah, okay, well, we can say who they are.
Megan is
Keeping you in
like
suspense. So
Oh, that's
here's a good
neat.
one. This is a good example of endosporulation. So this is Coccidioides, probably Coccidioides immitis. So coccidioidomycosis in this case, in this cat. Again, probably an ocular manifestation of systemic disease. You'd be worried about systemic mycosis in this kitty. And you can tell in particular because of the endosporulation. So these are fungal spherules, little daughter endospores inside, and then the cell wall ruptures and releases their little babies into the world.
Oh, is that a cat?
This is a cat, yeah.
Oh, that makes sense then.
Yeah, so cats tend to have more of these organisms than the dogs do. Like with dogs, you may search and find like one, maybe if you're lucky. There are other really cool examples of these guys sort of rupturing and stuff, but we've seen a lot of good examples already.
Yeah, it is a very interesting thing. There's some biological explanation for that I don't think we know, but in dogs, if you find one, you're kind of lucky. They're very easy to identify, so it's very unlikely that we're missing a lot of them. But in cats, the ocular coccidioides infection tends to have lots of organisms like this. And I don't know if anyone knows the reason why.
Yeah.
The difference between dogs and cats in this way.
You'd think maybe it's some sort of immunologic thing, but
Right.
anyway, I think we've shown you a lot of different examples of different stages. So the other thing is you could ask the geographic location of this guy as well, and it's Arizona. That's also pretty, I guess, expected or common for coccidioidomycosis in terms of endemic areas.
Dr. Salas here, Elisa here on the comment said that she got a case of coccidioides in a dog from Ohio with no travel history.
Oh no.
Yeah.
What?
I know.
Fungus will take over the world.
Yeah.
It's true.
Global warming is
Climate change.
changing. Yeah, climate change is changing all the boundaries.
Mm-hmm.
Bet that in 15, 20 years we have to, change all the information on textbooks regarding distribution of those in the US.
Right.
The plasma is endemic from south to north to
Yeah.
Canada.
Okay, I embarrassingly had to look it up. Double contoured wall was the term I was trying to come up with. Double contoured wall, fungal spherules, endosporulation, key things to know for this organism. Okay. But yeah, totally. Fungus and cockroaches are going to rule the world. It's true. You laugh.
It'll be only fungus. The tardigrades.
That's right, and tardigrades. We can't forget the tardigrades. Those adorable little guys. Okay, so here's a diagnosis for this case as well. And just a pair of very interesting fungal diseases in cats, maybe one that's a little bit more common and one that's maybe a little bit less common.
Right. I thought of something that I should have said with my case of the metastatic carcinoma, so I'm going to say it now. I did a PAS stain to look for goblet cells and didn't see any, but occasionally we will find goblet cells in those tumors, in those metastatic neoplasms, and then that's even more supportive of a respiratory or pulmonary, really sort of, main, anyway, origin, yeah. Yeah, I just wanted to share that.
Yeah, that's useful.
And we actually recently did IHC for, oh gosh, was it TTF1?
Right.
On a series of these, and it was actually a relatively small percentage that had positivity for TTF1, which is supposedly a marker of pulmonary respiratory carcinomas. Obviously, it's also a marker for thyroid carcinomas, but so anyway, that was kind of an interesting finding. That so few were positive.
Yeah.
I'm done.
Cool.
Signing off.
Okay.
Thanks, everyone.
Thanks for coming.
Talk at you
See
next
on here.
time. 2 weeks.
Thank you. I've never seen it. Oh, you never see it. Okay. The occasional